I had a patient, and it's fascinating how much systemic therapy come into play more into regard to the management of HCC. A patient, I said, your disease means that you should go for an embolization, and the patient refused. And I said, no, I heard that you have amazing new systemic therapies. I'm more interested in this. It's amazing that how the mindset is changing. And this brings me back to Peter in regard to, of course, where you all used as if we're doing nothing for 10 years with sorafenib being the only standard of care. Admittedly, we're doing a lot in between, and all experts in the field have been doing things globally in that regard. And then I've never seen a disease like this, where really like everything just evolved so quickly with so many options within a year. And let's start with the first one of which, Lenvatinib. So this was a non-inferiority study compared to sorafenib. Tell us a little bit more.
Yeah, when we started 2007 with sorafenib, the hope was there that would rapidly produce more drugs and more systemic options. Nothing happened. There were many negative trials, although a learning experience. We learned a lot. We had clear definitions, for example, that placebo-treated patients in second line live 8 months or so. That was very helpful to define the setting, but it was disappointing with respect to new options. And then it started with regorafenib in second line, and later on Lenvatinib entered the stage. Lenvatinib was tested in an open label design against sorafenib in first line, and it was a non-inferiority trial. And it was clearly a positive trial. The outcome was comparable, actually numerically better for Lenvatinib, and definitely opens the horizon in first line having at least another option, and which is probably interesting, also a slightly different safety profile. That is, as we are all aware, one of the critical things. Tumor efficacy is not all we have to ask for. Toxicity is extremely relevant, and now you have the option to at least make a smart decision, although we have no head-to-head comparison. But it's now opening the scene, and first line is offering more than just sorafenib. What we also have learned is that some surrogate endpoints have been in favor of Lenvatinib. PFS and TTP were better for Lenvatinib, although the overall survival data in the end were the same. What does that mean? It's one of these situations where we need to discuss how we correlate the surrogate markers, surrogate endpoints, and the and overall survival. But a definite step forward.
No, absolutely. I totally agree. If anything, the sorafenib Lenvatinib kind of in the 12 to 13 month equal survival, maybe, as Peter said, a small edge for the Lenvatinib, but at the end of the day, they are comparable. But interestingly, the PFS almost tripled for the Lenvatinib compared to sorafenib. And add to this, a new introduction in regard to responses. Remember that with sorafenib, barely responses exist, but with the Lenvatinib, responses were actually a real important part of the story. I mean, tell us about that. Like, what were the numbers there?
Yeah, so as you were saying, the PFS was nearly double or triple that, what you saw with sorafenib, and similarly, you saw significant improvements in terms of TTP, the time to progression, as well as the objective response rates. And so it really does, as Peter was saying, it makes you excited when you start to see significant improvements in time to progression and the response rates. However, it didn't actually translate into improved survival. And this does bring up the same discussion that we've been having in terms of, are these appropriate endpoints? Do these actually clinically matter if it doesn't translate into an improved survival?
I hear you, but again, to go back to the point, nonetheless, the response rate by RECIST 1.1 close to about 22, 23, 24%, and the modified RECIST 41%.
Yeah.
Wow.
Yeah, no, I mean, it's incredible when you take a look at these response rates. Once again, if you're a patient and you're like, I'm going to have some tumor response, but it's not going to actually improve survival, what does that actually mean?
So Riyad, for you as a IR specialist, like if I come to tell you, like in Lenvatinib, by modified RECIST, 41% response rate, how do you look at this?
Well, it's music to my ears as an interventional radiologist, because finally oncologists and hepatologists recognize the importance of response, because it does matter. Because you know as well as I do, if not better, that's the discussion that you have with your patient. For any patient that is on medication, on drug, on therapy, if they're not having toxicities that you're managing, the number one discussion point, I believe, is response. Show me that tumor. Is it smaller, et cetera? And so it really sort of opens up the idea that now you have a systemic agent that can provide with that high response rate, 40.6 or 41%, as you mentioned. But also now the reality is, are there now discussions that you can start to think to have in terms of using this therapy? Now I'm stretching a little bit, but I'm allowed to do that. The downstaging concept, right? Can you use that in bridging? I'm sure there's going to be some research on that. Can you use that in downstaging where local therapy fails, for example, to bring within transplant criteria? So I think it reinvigorates a discussion of response, which is an important one, and allows you to study response as a surrogate of survival, which has been shown in some clinical trials to be very important.
No, I hear you. I totally agree on that. And if anything, patients are very used and geared in regard to response because, you know, bigger, smaller, same, these are easy to reference. I mean, one day a patient really stunned me and I didn't even know what the answer. And he looked at me and said, so what's survival? And the best I could tell it that day was like, the more you see me, the better you are. Like, I couldn't come up with anything better than that. And this really just tells you how complex it is in regard to really the absurdity sometimes, or really the kind of, you know, the difficulty of understanding survival per se. But with this said, I mean, any experience or thoughts in regard to the side effects or adverse events that we can see with lenvatinib? How well tolerated is the drug?
Yeah, no, I think that, you know, as Peter was saying, I think the nice thing is that it appears to be better tolerated than what we saw with sorafenib. So when you take a look at the trial, you saw lower rates of hand-foot skin reaction with lenvatinib than we're used to seeing with sorafenib. You had slightly higher rates of some of the other adverse events like hypertension.
I think the most common is hypertension, correct?
Yeah, exactly. So you saw higher rates of hypertension, some higher rates of, you know, anorexia or weight loss. But I think the biggest thing when we've taken a look at TKI therapies is the hand-foot skin reaction, and that's really been one of the toughest things in terms of patients tolerating this as well as treatment. And so I think that all of us are going to welcome this in terms of an alternative therapy where you have significantly lower rates of hand-foot skin reaction.
Sure.